Hello everyone, welcome to my YouTube channel. This is Sir Steven, and for today we will be talking about the circulatory system as a part of your medical histology laboratory. This system comprises your heart, your cardiac valves, your cardiac conduction system, your arteries, your capillaries, your veins, and your lymphatics. Let's start with your heart. In macroscopic anatomy, your cardiac chamber structure will reflect the pressure and the volume physiology. You have also in your heart atrial sideness landmarks like the right appendage, which is larger in pyramid shape. Your left is finger-like shape. Your right atrial pectinate muscles are prominent. In your left, smooth except for the appendage. Your right atrium has your coronary sinus ostium, the limbus of oval fossa, the terminal crest, your sinoatrial node, and your atrioventricular node. We have also ventricular sideness landmarks like the right septal wall trabecular, the left septal wall smooth, the tricuspid chordal attachment to the right septum, the no septal chordal attachment on left, the muscles that separate your tricuspid valve from your pulmonary valves on your right, your mitral valve, and your aortic valves in continuity on your left. We have also your pericardium, which envelopes and encircles your heart. The epicardium is delicate serous layer adhering to your heart, whereas your pericardium proper, which is the parietal pericardium, forms your thick fibrous walled sac surrounding your heart. There is a space between the epicardium and the pericardium which contains 30 ml of cushioning fluid. Let's move on with the heart anatomy. The left is a view of a cadaver, which is a heart of the cadaver illustrating the right atrium in white arrow, the right ventricle is single blue arrow, the epicardium or the visceral pericardium in a curved black arrow, the parietal pericardium in a curved blue arrow, and the myocardium, which is in bold black arrow of your infundibulum. On your right is cardiomyocytes, which contains sarcoplasmic cross striations in a bold blue arrow, which are centrally placed nuclei in single white arrow, curved arrow, and their interconnections between the cells, which is in a single black arrow. All of these are facilitating cellular electrical coupling. On your left is an electron microscopic view of an individual myofilaments within a cardiomyocyte. This is around magnification of 14,000. The Z bands in a double blue arrow anchor the thin actin filaments. You have your M lines in curved blue arrow, which connect the thick myosin filaments, and they represent the center of the A band. This exists between the two Z lines. The mitochondria in a single blue arrow are abundant. On your right, the parallel stripes which running perpendicular to the long axis of the myocytes are referred to as your cross striations. These are resulting from alignment of hundreds of myofilament Z bands across the width of your cell. On your left, at the junctions between the interconnecting cells, we have your desmosome-rich intercalated discs, and they are seen as dense irregular eosinophilic lines in a single black arrow. On your right, brown atrophy is an age-related phenomenon and consisting of the accumulation of granular gold-brown lipofuscin or lipochrome. These are pigmentation that found around the cardiomyocyte nuclei in double blue arrow. On your left is a ventricular endocardium, which is comprised of a single layer of endothelial cells in a single black arrow with flattened inconspicuous nuclei and varying amounts of subendothelial connective tissue in a curved blue arrow. These are found on the ventricular luminal surface. On your right, thickened endocardium is seen normally in the left atrium and subvalvular portions of the ventricles. There is also an increased collagen fibrosis in a bold black arrow and elastic tissue. The endocardium also contains a thin, smooth muscle layer throughout much of the heart, which is in a white single arrow, curved arrow. On your left is the proportion of sarcoplasm to your nuclei in infant myocardium, which is much lower than in adults, consistent with the dogma that myocardial growth occurs via hypertrophy and not hyperplasia. On your right is an adult myocardium with an increased sarcoplasm relative to infants. It shows early features of abnormal or pathologic myocyte hypertrophy, including frequent binucleation of your myocytes in a single blue arrow and nuclear darkening and enlargement. On your left is in a severe abnormal hypertrophy. The nuclei are dramatically enlarged, hyperchromatic, and irregular. You also have to note the absence of mitosis. Nuclear features are a more reliable measure of hypertrophy than other cell width measurements due to the complex 3D architecture of your cardiomyocytes. On your right, your subendocardial myocardium is furthest from coronary blood flow but too deep to receive oxygen and nutrients from your luminal blood. In the chronic ischemia, the starved cells will show vacuolation. On your left, the atrial walls are thinner than the ventricles but still contain the 3 tissue layers. The atrial endocardium in the curved blue arrow is typically thicker than in the ventricles. The myocardial architecture is also more disorganized and haphazard. Adipose infiltration in the myocardium is also common in the atria in a bold black arrow. On your right, aside from being thicker, the ventricular myocardium is also more compact and composed of layers of myocyte fascicles successively oriented in alternating directions. On your left is the tip of a papillary muscle. It is being stained with trichrome to highlight the interdigitation of myocardium and dense collagenous valve apparatus, which is the tendinous cord tissue, in a curved white arrow. Cross-sections through the tips of the papillary muscle may falsely appear to have increased interstitial fibrosis, though this is a normal anatomic phenomenon. On your right, similar to the papillary muscle tip, the dense collagenous interventricular valve annulus also shows some interdigitation with your myocardium. On your left is the intramyocardial vessels. As the penetrating arteries and other intramyocardial vessels course through the myocardium, they are surrounded by a layer of connective tissue. This is normal and should not be confused with pathologic interstitial fibrosis. On your right, the trichrome staining highlights the collagenous connective tissue surrounding your intramyocardial vessels. Note the absence of collagenous fibrosis between the myocytes where no vessels are seen. On your left, contraction bands are thick perpendicular lines in a single blue arrow with much thicker than cross striations or intercalated discs within the myocytes are caused by clumping together of the contractile elements. In full thickness sections of the heart, this indicate infarction, but in biopsies, they do not, rather due to biopsy-related trauma. On your right, hydrophilic polymer coatings in a single blue arrow are common on endovascular catheters and may embolize to coronary arteries. This is an artifact that is not typically pathologic. Let's move forward with the cardiac valves. In the macroscopic anatomy, we have semilunar or the ventriculo-arterial valves. These are your aortic and pulmonary valves, which is in anatomy is very similar. We have 3 shirt pocket-like cusp or leaflets which are arranged radially. The retrograde blood flow from aorta during diastole will fill your cusp pockets, occluding the valve orifice. The outer sheath of these valves varies in composition at different levels. We have the line of fine fibrosis developing toward the top of the aortic cusp along line of closure or coaptation. Above this line, there is redundant and fenestrated tissue called the lunula. At the cusp edge midpoint is a pyramidal focus of your fibrosis. We call it the nodule of Arantius. from which often the emanating fine strands of fibrous tissue or the lumbal excrescences. The atrioventricular valves are consisting of mitral and tricuspid valves. Anatomy is very similar. Each is suspended from fibrous annulus that separates atria from the ventricle. Each are tethered from below, preventing the prolapse into atria during systole by tendinous cords attached to the papillary muscle, the outcroppings from the ventricular muscle wall. The mitral valve has two leaflets, the anterior and posterior, supported by two papillary muscles, one at each commissure. Your tricuspid valve has three leaflets, the anterior, posterior, and your septal, and they have three papillary muscles. In your macroscopic anatomy, the semilunar and the atrioventricular valves share same trilaminar histoarchitecture. Their thickness and proportional contribution of each layer will vary. The fibrosa is a dense collagenous layer in continuity with annular connective tissue, which are bounded on either side of the thin layer of elastic fibers. The elastic layers diminish towards the free edge of the leaflets, and this layer continues as tendinous cords of your atrioventricular valves. Your sphingiosa, the central layer composed of loose connective tissue, fibroblasts, and valvular interstitial cells, are the most prominent near annulus. In semilunar valves, atrial myocardium, the nerve bundles, and lymphatics may infiltrate the spongiosa near the annulus. This layer also gives rise to surface distally in semilunar valves to become the auricularis layer. The ventricularis is the most elastic fiber-rich layer with multiple layers of elastic tissue, and they line the ventricular surface of both semilunar and atrioventricular valves, and also they coats the tendinous cords. Let's start with the image on your left. It shows the semilunar valves after removal of the great arteries. The pulmonary artery in a bold black arrow is anterior, and the aorta in a single blue black arrow is posterior, with the right coronary in a curved single blue arrow branching from the aorta. The right is the atrioventricular valves in a tricuspid in a curved blue single arrow, and mitral in a black single arrow are shown in this four-chamber view of the heart. The valves are suspended from the annular rings and tethered to the papillary muscles in a bold blue arrow by tendinous cords, a single white arrow. On your left is a three distinct valvular layers are the fibrosa in a single black arrow, the spongiosa in a bold black arrow, and the ventricularis in a bold blue arrow. A fine line of elastic tissue is seen beneath the endocardium overlying the fibrosa layer in a curved blue arrow. The ventricularis layer is the richest in elastic tissue, as shown by the heavy black band on this elastic stain. On your right is a photo showing the three distinct valvular layers, with the fibrosa in a single black arrow, the spongiosa in a bold black arrow, and the ventricularis in a single blue arrow, with the subendocardial elastic layer in a curved blue arrow. On your left is a photo demonstrating the continuity between the aortic valve and the elastic wall of the aortic root in a curved blue arrow, along with a gradual diminution of the ventricularis layer in a single black arrow and the fibrosa layer toward the free edge of your cusp. On your right, there is a gradual diminution of the ventricularis layer and fibrosa layer in a single black arrow, with progression toward the free edge of the cusp as shown here. The spongiosa layer expands to the becoming the most prominent at the free edge in a blue bold arrow. On your left, is the myocardium extending along with the lymphatics, the fat, and the nerves into the proximal portion of the valve substance in a single black arrow. The heavy band of the elastic tissue in the ventricularis layer in a curved blue arrow is also prominent. On your right is a section showing a thickened portion of a tendinous cord. The core in a black bold arrow is a dense collagen that is continuous with the valve fibrosa layer, and there is a coating of a prominent elastic tissue in a curved blue arrow showing or covering the cords as well. Let's talk about the cardiac conduction system. The cardiac conduction system, in its macroscopic anatomy, we have the sinoatrial node or the SA node, your atrioventricular, the AV node, your microscopic anatomy, the SA node is a compact and polyhedral myocyte surrounding by dense collagenous tissue. We have also your sarcoplasm and cross striation, which is less prominent than your typical myocytes. The sinus nodal artery courses through the sinus node. The autonomic nerve fibers and the ganglia are seen in the vicinity. Your AV node is a compact bulb of smaller polyhedral myocytes merging with larger stellate to spindle myocytes with vacuolar sarcoplasm towards the bundle of His. They are mesothelial-like cells, and cystic structures are occasionally intermixed, also with atrioventricular nodal artery which courses through the AV node. The connective tissue surrounds node, insulating the adjacent myocardium. The autonomic nerves and lymphatics are seen in the vicinity. The bundle of His and the bundle branches. We have your Purkinje cell, which is a term applied to all the cells in your left bundle branching and distal right bundle branch because they are larger than the myocardial myocytes, and the feature cytoplasm that is more vacuolated. As with all the conduction system cells, the Purkinje cells are myocytes. It also contains myofibrils by EM, and differences from normal cardiomyocytes. They have the absence of T tubules and striking abundance of cell-to-cell junctions. On your left is an illustration showing the approximate locations of the sinus node in a curved single blue arrow, subepicardial, the atrioventricular or the AV node in a white single arrow, the subendocardial, and the His bundle in a bold white arrow, as well as the bundle branches, the subendocardial. On your right, the conduction system will coordinate the early cardiac contraction. Every beat will originate in the sinus node and propagate through the atrium to the AV node. The AV node, the His bundle, and the bundle branches control the contraction of the ventricles. On your left is a heart removed at an autopsy, illustrating the pulmonary arteries. In a bold black arrow, the aorta in blue single arrow, the superior vena cava in a curved black arrow, and the left pulmonary vein confluence in a white bold arrow. And this is when viewed up from above. On your right is a block tissue in a curved white arrow along the lateral border near the superior vena cava connection, containing the sinus node that has been removed from this heart. Internally, a segment of the terminal crest in the right, the atrium, is being removed with this block. On your left is viewed from the endocardial aspect. This excised tissue will consist of a portion of a terminal crest in a single black arrow with a few pectinate muscles in a curved white arrow is being attached. The overlying epicardium is not seen, facing down, is intact. On your right is, after serial sectioning, the belly of the terminal crest in a single black arrow is now seen in cross-section in each piece. The pinpoint sinus nodal artery in a curved white arrow can also be seen in many of the sections in identifying the locus of the node. On your left is a trichrome stained section at low magnification showing the atrial or the terminal crest myocardium in black bold arrow, sinus node arteries in a single blue arrow, and the sinoatrial node itself in a curved black arrow. They are characterized by intermixed dense collagen and small polygonal myocytes. On your right is a cross-section that illustrates the dense connective tissue-rich sinoatrial node tissue in a curved black arrow surrounding the sinus node arteries. On your left is a trichrome stained section showing a portion of the normal sinoatrial node with the accompanying sinus node artery. This is in curved white arrow. The nodal myocytes show prominent vacuolization in a single white arrow. On your right is the right side of the heart that has been opened through the tricuspid valve. Koch triangle can be visualized as imaginary lines connecting the roof of the coronary sinus ostium in a curved black arrow, and the tricuspid annulus at a point directly below the coronary sinus ostium in a bold black arrow, and the membranous septum in a single blue arrow. On your left is a view showing the right side of the heart, opened through the tricuspid valve after the tissue block containing the Koch triangle, including the AV node that has been removed in bold white arrow. On your right is a view demonstrating the excised tissue block in a curved white arrow, included the interventricular septum and part of the aortic valve and aortomitral fibrous continuity. On your left is a view demonstrating that the excised tissue block in a curved white arrow also included the portion of the anterior mitral valve leaflet, all of which are forming the aortomitral fibrous continuity. On your right, the AV node tissue block is shown with a portion of a posterior tricuspid leaflet in curved black arrow that traverses the rightward aspect diagonally. The membranous AV septum is also seen in white single arrow. On your left is a left-facing aspect of the AV node tissue block, which is shown here with membranous septum in single black arrow and pockets of two aortic valve cusps in a bold white arrow. On your right, serial cross-sections through the excised AV node tissue will block illustrate portions of the tricuspid valve leaflet in a curved black arrow, the membranous AV septum in a bold white arrow, and the aortic valve cusp in a single white arrow. On your left is an intermixed dense collagen and small myocytes comprising the AV node in a black bold arrow, situated in the annular connective tissue, insulated from the atrial and ventricular myocardium, a portion of which the tricuspid valve leaflet is also seen in a curved black arrow. On your right, the right bundle branch in a curved black arrow consists of a thin, cord-like wisp of conduction system myocytes arising from the main His bundle in a bold black arrow. The bundle of its small size step sections through the paraffin block are typically required to see it well. On your left is the left bundle branch in a curved black arrow, which is larger and broadly spaced out beneath the left ventricular outflow tract endocardium. These specialized myocytes are smaller than the adjacent normal myocardial myocytes, and these may also be more vacuolated. On your right is a trichome stained section showing a portion of the AV node with accompanying AV nodal artery in a curved blue arrow. The conduction system myocytes are compact and show vacuolization of the sarcoplasm in a single white arrow, and there is also dense collagenous connective tissue in the node in bold black arrow. Let's move on with the arteries. In macroscopic anatomy, we have elastic arteries. These are the first order branches of aorta, the carotid, subclavian, proximal, renal, and iliac, and also the internal mammary arteries. These walls composed of multi-elastic layer of concentric strata. We have also muscular arteries, arteries that are segments between elastic and arterioles. These are distinct internal and external elastic lamina. We have also arterioles, which are smooth muscle only and no definite elastic layer. With microscopic anatomy, we have interintimal layer, the tunica intima, which is a single layer of an endothelial cells with subendothelial loose connective tissue and smooth muscle cells. We have the medial layer, the tunical media, which are multiple layers of smooth muscle cells with associated elastic tissue. We have your adventitial layer, or the tunica adventitia, which are dense connective tissue. This is a schematic showing the spectrum of vascular segments from elastic artery to capillaries and back again to the great veins. For each arterial segment, the histologic structure reflects its function. The aorta is rich in elastic tissue, which helps provide recoil to sustain blood flow through diastole. The muscular arteries have so much elastic properties but also substantial smooth muscle that contracts and relaxes to alter luminal flow. Arterioles are the most entirely smooth muscle and serve as the main locus of control for peripheral vascular resistance. On your left is a photomicrograph of a muscular artery showing the normal configuration and appearance of the intimal curved blue arrow, medial single black arrow, and adventitial layers in a bold black arrow. On your right is an elastic stained section of a muscular artery illustrating the normal configuration and appearance of the intimal in a curved black arrow and medial curved single arrow and adventitial layers in a bold black arrow. The stain also demonstrates the internal in a curved blue arrow and external in a single blue arrow elastic lamina. On your left is a lumen of this artery, which is elongated and narrowed. It is rather than the usual circular appearance, but this reflects an artifact of compression during tissue fixation. On your right is a perpendicular branch in a bold blue arrow which arises from a muscular arteries. Note the difference in caliber between the main artery cross-section and branch longitudinal section, and note also that the tissue layers and elastic lamina are continuous from the main artery to the branch with thickened intima at the junction and curved black arrow. On your left is a photomicrograph of a muscular artery in cross-section which demonstrate the elastic staining, and it's not always needed to see the wavy refractile elastic fibers of the internal elastic lamina in curved black arrow. On your right is beyond the adventitia. This is the single black arrow. There is adipose tissue, which the nerve fibers in a curved blue arrow, and the small vessels of the vasa vasorum in a bold black arrow can be found. The vasa vasorum run parallel to the artery but give rise to perpendicular branches that penetrate into the media to supply the smooth muscle cells. On your left is a longitudinal section of an arterial segment as opposed to cross-section. It shows the same tri-layered architecture with intima in a curved blue arrow, the media in a single black arrow, and the adventitia in a bold black arrow. On your right is an elastic stain of a longitudinally sectioned muscular artery demonstrating the internal in a curved blue arrow and external elastic lamina in single black arrow. On your left is a photomicrograph comparing the H&E and elastic staining of the aortic wall. Note the relatively thin intima layer. Nearly the entire thickness of the wall is comprised of media with alternating elastic fiber and intervening smooth muscle layers. The adventitia is also prominent with a large vasa vasorum readily apparent. On your right is a normal aortic wall which is composed of multi-layered strata of wavy elastic fibers. On your left is an asymmetric bulging in a curved blue arrow is seen on one side of this vessel, otherwise in cross-section. Elastic staining shows that this is composed of medial layer. The orientation of the medial smooth muscle is altered relative to the cross-sectional areas, another clue to tangential sectioning. On your right is a slightly tortuous segment of the muscular artery which is shown with a line and curved black arrow representing a tangential plane that could give rise to an artificial bulge secondary to sectioning artifact. On your left is the internal mammary arteries that are unique as the smallest caliber elastic arteries in the arterial tree. These are used as conduits in coronary bypass surgery, so this feature is helpful in distinguishing conduit vessels from the native target vessel histologically. On your right is an artery containing an atherosclerotic plaque. This is in a single black arrow. Note the dissolution of the internal elastic lamina in a curved black arrow and the atrophy of the media underlying the plaque in a bold blue arrow. This is compared to the medial thickness opposite in bold white arrow. On your left is an elastic staining of this muscular artery showing the atherosclerotic plaque. This is in single black arrow in the intima inside the internal elastic lamina. The atrophy of the underlying media in a curved blue arrow and focal calcification in a bold black arrow are also seen. On your right is a paraffin section of the muscular artery showing the extensive calcification in a curved black arrow. These are centered on the internal elastic lamina, and this is largely an age-related phenomenon and of no major clinical significance. On your left is a photomicrograph showing an elastic artery with a chronic medial dissection plane. A new cavity or the false lumen has developed in a dissection plane, a curved blue arrow within the media filled with old organized thrombus in bold black arrow. On your right is a vessel, markedly abnormal vessel, showing an important hallmark of inflammatory damage caused by vasculitis. The inflammation causes discrete breaks in the internal elastic lamina, and there is replacement of smooth muscle with collagen and fibroblast, or the fibrosis. Develop internal elastic layer beneath the intima. The small saphenous vein branch has a substantial muscular media in a single black arrow. There is also abundant adventitial elastic tissue in a bold blue arrow, but it does not form a discrete lamina. The adventitia is stratified with longitudinal and circumferential bands of smooth muscle and collagen. On your right is a longitudinal section of a saphenous vein branch. Shows that most of the adventitial muscle bundles run parallel to the vessel length. On your left is the capillary surrounded by a loose connective tissue matrix that are component of classic wound healing response. By light microscopy, the endothelial cells in a curved white arrow and supporting pericytes are clearly seen in single blue arrow. On your right, these capillaries in single blue arrow are composed of a single endothelial cell circumscribing the lumen. They also run alongside the renal tubules in a bold black arrow and form part of the vasa recta, running parallel to the Henle loops in the renal papilla. On your left is contiguous capillaries comprising the bulk of the alveolar septal structure, allowing maximum surface area exposure for gas exchange. Several capillaries with open lumina can be seen in this section in single black arrow. On your right is a continuous type capillaries account for the blood-brain barrier, which limits solute exchange in central nervous system circulation. As with other capillaries, endothelial cells in a curved blue arrow and supporting pericytes in a single white arrow are seen by light microscopy. On your left is an electron micrograph showing a glomerular capillary fenestrated endothelium. The endothelial cytoplasms forming a discontinuous dashed line to the left of the glomerular basement membrane in bold white arrow. The clear spaces or the pores in a single blue arrow between the cytoplasm will allow the free communication with the extracellular compartment. On your right is a photograph of adjacent vein in a blue bold arrow, lymphatics in a curved blue arrow, an artery in a single black arrow in cross-section, highlighting their structural differences. On your left is a section containing a medium-sized vein in a single black arrow and accompanying artery in bold blue arrow. Veins lack an internal elastic lamina and have thinner, less orderly medial smooth muscle. The vein adventitia is the most prominent layer, and most adventitial bundles are oriented longitudinally. On your right is this vein in a single black arrow has an irregular lumen profile and prominent longitudinal adventitial collagen bundles. An artery is next to it for comparison in bold blue arrow. The nerve is also seen in this neurovascular bundle in curved black arrow. On your left is high endothelial venules in a bold blue arrow. Within the lymph nodes are specialized venial segments that serve as an active site of leukocyte homing and migration. The endothelial cells are cuboidal rather than flattened. Small lymphocytes are seen filling the lumen and within the vessel walls. On your right is the endothelial cells that are cuboidal rather than flattened within these high endothelial venules in a bold blue arrow in a lymph node. Small lymphocytes are seen filling the lumen and within the vessel walls. On your left is two dilated lymphatic vessels in a curved blue arrow that are seen within the organizing granulation tissue. Lymphatics are composed of a single layer of endothelial cells with minimal supporting connective tissue. There is little to no muscular medial wall, and they often have irregular luminal contours. On your right is the veins in the lung that are recognized by the absence of an accompanying airway. No internal elastic lamina is seen here. The adventitial elastic fibers in a curved blue arrow are coarse and poorly organized. On your left, venules and lymphatics in the lung travel in the interlobular septa. The venules in a bold blue arrow have a better developed elastic adventitia and contain blood. Lymphatics in a curved white arrow show more irregular luminal contours, thinner walls, and no luminal blood cells. On your right is a lymphatic channel in a bold blue arrow showing a complex luminal branching and some associated extranodal lymphoid tissue in a single black arrow. A small vein in a curved blue arrow is also present for comparison. Lastly, on your left is a hybrid vessel wall with arterial or the internal elastic lamina in a single blue arrow, and venous, absent internal elastic lamina and prominent adventitial collagen and longitudinal smooth muscle in a bold blue arrow. Features are also seen in this arteriovenous malformation or the AVM. On your right is an irregular cavernous lumina and vessel walls showing venous features, absent internal elastic lamina and prominent adventitial bundles are seen in this AVM. Disproportionately thick walled vessels are also embedded in the walls of larger vessels, shown new here in this single blue arrow. And that's it. Thank you so much for watching for our circulatory system. Up next is the nervous system of your medical histology laboratory. Have a nice day, everyone.